Hi, everybody. Welcome to week 7. And this week we are going to discuss drugs that affect the respiratory system. So let's get started. All right, let's talk about inhaled beta 2 agonists. And you'll see these used so much in patients who have asthma, they have COPD, and I will even prescribe it in patients who have bronchitis and are wheezing. I find that it can give them some relief. Um, and the mechanism of action in these inhaled beta 2 agonists, it's really interesting, I think. It relaxes the smooth muscle in the airway. And how does it do that? It does that by stimulating beta 2 adrenergic receptors, and this increases cyclic AMP and antagonizes the mechanisms of bronchoconstriction. So you can see there is an actual physiologic occurrence that happens that makes these drugs effective. All right, so let's talk about contraindications a little bit. Mainly, if you're pregnant, you want to look at it because if you're nursing, if you're nursing, it can decrease the blood sugar in the baby. But honestly, I had a physician say to me once, when I was doing my OB rotations, and he said to me, what do you want to do? Do you want mom to be able to breathe or worry about the baby's blood sugar? We'll worry about the baby's blood sugar. We can fix that. So we always are looking at the big picture, all right? And this can make people have a tremor, rapid heartbeat, because it's stimulating. It's stimulating that that process causes a stimulation. So I have severe asthma, and when I first started using these many years ago, it would make my heart race, and it has no effect on me at all anymore. I guess I've gotten used to it. But these are things that you want to discuss with your patient if you're prescribing them and they've never had one before. You want to make them alert of the fact that it may make them shaky. Gosh, it would make my hand shake like crazy after I used it. Um, excuse me. Let them know it may make them shaky. And beta 2 agonists can cause hypokalemia, but really in super high doses. And it can be increased by other potassium depleting drugs like corticosteroids, loop diuretics, and theophylline. Theophylline is a drug that we don't use anymore. We used to use theophylline pretty regularly in asthmatic patients. Oh, it's a horrible drug. When they gave it to me, I got such a terrible headache I could not lift my head off the bed. Um, so it's not used anymore. But we use steroids a lot, and we're trying to with these biologics that are coming out. We're trying to get away from using steroids because they have so many. They're wonderful. I love steroids, but they have so many bad effects to them that we need to really be using them judiciously. Drug selection, you're going to get the generic. I just dislike the generic. I like Ventolin. The two major brand names are Pro Air and Ventolin. Ventolin is my personal favorite, but I end up always getting the generic, and so I'm used to it now. And then you want to just monitor the patient for their effect. I mean, what are they using it for? Do they have asthma? Do they have COPD? So you're going to do lots of monitoring on your patient to ensure that they are stable and hopefully improving. And you're going to educate the patient about the side effects of an inhaled beta 2 agonist. But we use these all the time in practice. We've got the short acting and the long acting. Now, most people today want the long acting because they're usually once a day dosing. That's fabulous. And the mechanism of action It's a complicated process, just like all drugs are. It blocks the muscarinic receptors on the bronchial smooth muscle and the exocrine gland cells in the bronchial passages, and blocks acetylcholine activity in the airway, thus relaxing the airway muscles, reducing mucus congestion, and eases breathing. Okay, some of the most common brands of the long-acting muscarinic are Spiriva. What else? Advair can be one, but it's got a steroid in it too. So a lot of them are combination medications that have a steroid in them too. Examples of some of the short acting is Combivent and Atrovent. Those are both short acting. So what does that mean? That means that they have to be taken more often. Right, let's talk about inhaled corticosteroids. And oh my gosh, lots and lots of people with COPD always are on an inhaled steroid. People with asthma are often on inhaled corticosteroid. And how do they work? Well, they bind to intracellular glucocorticoid receptors, and that regulates gene expression through glucocorticoid response elements. So this down the road inhibits the transcription of many inflammatory genes in the airway, epithelial cells, and thus reduces inflammation in the airway as well. And the use of corticosteroids really, I'm trying to think how long. I think they've been out at least 20 years now. But um, the evolution of this drug really um, made a huge difference in many people's lives with COPD and with asthma. It's amazing how people went from being homebound to being able to play sports and all of that. The main side effect of these drugs is the development of candidiasis in the mouth or a yeast infection. It's advisable to instruct patients to rinse their mouth with water after use. That will help prevent the steroid from accumulating on the tongue, and it reduces the risk of them developing this yeast infection in the mouth. But it's not a huge deal. If they get a yeast infection, we're just going to treat it with nystatin, and it'll go away right away. Um, on high dose corticosteroids over a long period of time, there is a risk of some side effects like bruising, increased risk of diabetes, or thinning of bones, osteoporosis. But this is long term use of these medications. All right, so some of the things that you want to instruct your patient, of course, you want to advise them of the risk of thrush. They may have an increased appetite, bruising, infections, thinning of the bones. And in children, we have identified that long-term use, it can cause slow growth We didn't think that that could happen before. We've just identified that it can. However, it's not a contraindication for use. All right, let's talk about antihistamines. All right. First generation diphenhydramine, which is Benadryl, and second generation loratadine, which we're talking about Zyrtec, Allegra, Zyzol, and well, I can't remember what the other one is. It's escaping me. But they work really, really good to suppress allergies in patients. It also works well if a patient is having an allergic reaction. So if you are exposed to something that your body is allergic to, your body is going to produce histamine. Okay, so imagine that you have a body and it's filled with H's, right? H all over. That's histamine. Histamine causes you to have runny nose, itchy eyes, sneezing, irritated throat, all those nasty things. And in severe cases, if you have an allergic reaction, it can cause anaphylaxis, right? So histamine is not really a good friend of ours. But if we take a first generation antihistamine like Benadryl, that's an antihistamine. So it enters your body and it binds with all of those H's that are in your body. And if it's bound to the H's can't do anything. They can't make you have watery eyes or sneeze or feel miserable because it's all bound. Now, I tell patients that sometimes it takes several doses before you get the full effect of the antihistamine because you may have more H's in your body than H's in a dose of medicine, okay? Or blockers, H blockers in the dose of medicine. So it may take a few days. Now, first generation antihistamines cross the blood brain barrier pretty easily, and they can make you super tired. Me, I take a Benadryl, boom, in 10 minutes I'm out, okay? But they do work exceptionally well in an allergic reaction, especially an anaphylaxis reaction. So that would be my go-to if I thought somebody was having an anaphylactic or going that way, okay? Benadryl. The second generations take a little bit longer. Their onset of action takes a little longer. Out of the 4 that are on the market, why can't I remember the first one? Whatever. Zyzol has the quickest mechanism of action, so that's the one that I am recommending to patients now. Okay. And what are the side effects? Who shouldn't? Some, believe it or not, some people are allergic to an antihistamine. I have seen that on patients' medical records. I don't know what's going on with that, but they say that they are allergic to antihistamines. So I'm not going to disperse that. Of course, they can make you dizzy, drowsy, and the second generations. I don't care what anybody says, they can make you a little drowsy, especially Zyrtec. So I advise my patients who have allergies that are taking it for that to take it at night. All right, let's see. Many people take antihistamines every day because they have year-round allergies, and it's really not a huge deal. Um, I always keep Benadryl around just because you never know when someone's going to have an allergic reaction that you may not be aware of. Um, Antihistamines are also good for itching. So if a patient develops hives, I'm giving them Benadryl. That's going to help get that away. But again, if someone's having an allergic reaction to something, so say they ate shellfish and they're allergic to it and they're having an allergic reaction, they may need to take that antihistamine, and they may be on prednisone also for 5 to 7 days. So it may take that long to get all of that stuff out of their system before they can stop taking it. So advise patients not to use it and not to stop it prematurely. Okay? I think that sums that up. All right, let's talk about montelukast. Montelukast is a leukotriene receptor antagonist. So very much like the histamine, where the histamine, antihistamine binds with the histamine in the body, montelukast binds with leukotriene D4 in the lungs, resulting in a decreased inflammation and relaxation of the smooth muscle. And this drug has been out since 1998, so it's been around for quite a bit. So we use this for asthma patients, and exercise-induced bronchoconstriction, and seasonal allergic rhinitis. So those are the patients we use it for. This isn't a drug that we're going to use in an asthmatic patient unless they have allergies as well. All right. Evening doses are best, and we generally use a 5 milligram dose for patients that are age 6 to 14, and 4 milligrams for 12 to 5. And then once they get to 15, you can give them the 10 milligram adult dose. All right, so who are we going to worry about? Patients who have hepatic insufficiency. There isn't any dose adjustment, but we need to keep an eye on it more closely. It's the same thing with renal insufficiency. We need to evaluate that more often. Pregnancy, there has not been a drug-associated risk. And breastfeeding, we know that low levels of montelukast appear in the breast milk, and it isn't expected to cause any adverse effects. So what are the side effects of this drug? And we just really, these just really came out, okay? We have had patients have some neuropsychiatric events from montelukast, so they're a little bit more cautious about distributing this and evaluating patients a little more closely. So during treatment, some patients with asthma can develop systemic eosinophilia, vasculitis, and headaches, upper respiratory signs like rhinorrhea, laryngitis, auricular otitis, cough, conjunctivitis, nausea, vomiting, itching, eczema, atopic arthralgias, anaphylaxis, and hepatotoxicity. So we definitely need to keep a close eye on our patients who are using this. When I first started working, it was used much more than it is now. But it is a good drug. I have seen patients with debilitating asthma be able to function well by taking this. All right, let's talk about antitussives. Now, not many prescribers prescribe codeine cough medicine anymore. I was really surprised, and that's really the end all be all. So over the counter cough medicines really don't do a whole bunch. Antitussives work by inhibiting a coordinating region for coughing located in the brainstem, disrupting the cough reflex arc. So when we're giving someone a cough medicine, they have to be very diligent about taking it carefully, because we don't just want to suppress the action of the brainstem very much, because what happens? That regulates all of our breathing and all of the stuff that keeps us alive. So dextromethorphan, that's the medication you buy over the counter, like Robitussin or other medications that have a DM in them. That's dextromethorphan, and it suppresses a cough by depressing the cough center in the medulla oblongata. or the cough receptors in the throat. I don't see huge help with patients with those. Um, so what do I use? I use Phenergan and DM, Phenergan DM. Uh, so I use promethazine, dextromethorphan. That's what I use. And patients take a teaspoon 4 times a day for cough. And it doesn't have codeine in it, but it acts like it does. And it is superior over other medications. So, let's talk about interactions. Let me find side effects. What you would expect: dizziness, drowsiness, GI symptoms. Um, Actually, hallucinations are a side effect as well. So we want to avoid that. Are there any drug interactions? Let me see. Um, all right. So you want to tell your doctor if you're taking other products that cause drowsiness, like opioids. There you go. Codeine, hydrocodone, alcohol, marijuana, drugs for sleep or anxiety, like alprazolam, lorazepam, zolpidem, or muscle relaxants, like carisprolol or cyclobenzaprine. Very, very good. I'm glad that we saw that because that's important stuff. All right, let's move on. All right, let's talk about decongestants. Decongestants can be very helpful to patients when they've just got that crazy nose that's blocked up and they cannot get air in or out. It's driving them out of their mind. Decongestants work great. They do the high potency decongestants have to be bought through the pharmacist because of the risk that is of them, because you can make drugs out of them. There are lower potency decongestants out in the shelves, but they don't work that good, I don't think. How do they work? Well, their action is an activation of the postjunctional alpha adrenergic receptor found on precapillary and postcapillary blood vessels of the nasal mucosa. And what does that do? It shrinks that tissue. It causes vasoconstriction. And that vasoconstriction is now going to allow you to breathe, right? Oh, it's wonderful. All right. But of course, there are side effects. I personally don't tolerate them well because I just don't. They make me too shaky. If a person has elevated blood pressure, they should not be taking decongestants. Although all the time I find that my patients are on blood pressure meds and taking them, and then I have to go through the whole teaching episode. But side effects can be pounding heart, headache, insomnia, nausea. All of those things they're no fun. People who should avoid taking them are diabetics, high blood pressure, and hyperthyroid patients. So we want to ensure that when we are discussing with our patients, and education is key. Remember, when you're writing those SOAP notes, I want you to thoroughly document the education you are providing for your patient. That you are going to advise them if they have high blood pressure, they cannot take these. That there are two different kinds: high dose behind the pharmacy and lower dose on over the counter. They can have a pounding heart, headache, shakiness. You shouldn't take them if you are diabetic or high blood pressure, or if you take those medications affiliated with that. Okay. And the examples of those are, Sudafed is the most common one that you'll see. And I tell my patients, I explain it to them like this when they're trying to figure out what medication to take. If you're drippy, 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 you want to take an antihistamine because that's going to dry you up, right? If you're congested, you can't breathe out of your nose, you want to take a decongestant because that will open up your nose, you'll be able to breathe. If you have both, they have combination drugs like Zyrtec D or Allegra D that has the antihistamine and the decongestant in it as well. So you have to treat the symptoms that you're experiencing. I also advise patients that anything that you buy over the counter is not curative. It's going to help make you feel better for a few hours, but it will wear off, and then you can take it again. If you don't have any improvement in your symptoms within 5 days, you should be reevaluated or to ensure that they have not developed an infection. They should never feel worse than they do right now. I always say that to my patients, that they should never feel worse than they do right now. If at any time they feel worse, they need to be reevaluated. So not wait that 5 days if that happens. So I hope that you found this helpful. Please, if you have any questions or comments, let me know because I want to ensure that these are as useful as possible to you all.